Page 59. Diabetes Solution, by Dr. Bernstein. Part 1. Before you start. Chapter 1. Diabetes, the Basics. 1.4. Blood sugars, the non-diabetic versus the diabetic. Since high blood sugar is the hallmark of diabetes, and the cause of every long-term complication of the disease, it makes sense to discuss where blood sugar comes from and how it is used and not used. Our dietary sources of blood sugar are carbohydrates and proteins. One reason the taste of sugar, a simple form of carbohydrate, delights us is that it fosters the production of neurotransmitters, principally serotonin, in the brain that relieve anxiety and can create a sense of well-being or even euphoria. This makes carbohydrate quite addictive to certain people whose brains may have inadequate levels of or sensitivity to these neurotransmitters, the chemical messengers with which the brain communicates with itself and the rest of the body. When blood sugar levels are low, the liver, kidneys, and intestines can, through a process we will discuss shortly, convert proteins into glucose, but very slowly and inefficiently. The body cannot convert glucose back into protein, nor can it convert fat into sugar. Fat cells, however, with the help of insulin, do transform glucose into saturated fat. The taste of protein doesn't excite us as much as that of carbohydrate. It would be the very unusual child who'd jump up and down in the grocery store and beg his mother for steak or fish instead of cookies. Dietary protein gives us a much slower and smaller blood sugar effect, which, as you will see, we diabetics can use to our advantage in normalizing blood sugars. The non-diabetic. In the fasting non-diabetic, and even in most type 2 diabetics, the pancreas constantly releases a steady, low level of insulin. This baseline, or basal, insulin level prevents the liver, kidneys, and intestines from inappropriately converting bodily proteins, muscle, vital organs, into glucose and thereby raising blood sugar, a process known as gluconeogenesis. The non-diabetic ordinarily maintains blood sugar immaculately within a narrow range, usually between 70 and 95 mg/dl, milligrams per deciliter, with most people hovering near 83 mg/dl. There are times when that range can briefly stretch up or down as high as 160 mg/dl and as low as 65 but generally, for the non-diabetic, such swings are rare. You will note that in some literature on diabetes, normal may be defined as 60 120 mg/dl, or even as high as 140 mg/dl. This normal is entirely relative. No non-diabetic will have blood sugar levels as high as 140 mg/dl except after consuming a lot of carbohydrate. Normal in this case has more to do with what is considered cost-effective for the average physician to treat. Since a post-meal, postprandial, blood sugar under 140 mg/dl is not classified as diabetes, and since the individual who experiences such a value will usually still have adequate insulin production eventually to bring it down to reasonable levels, many physicians would see no reason for spending their valuable time on treatment. Such an individual may be sent off with the admonition to watch his weight or her sugar intake. Despite the designation normal, an individual frequently displaying a blood sugar of 140 mg/dl is a good candidate for full-blown type 2 diabetes. I have seen non-diabetics with sustained blood sugars averaging 120 mg/dl develop diabetic complications. Let's take a look at how the average non-diabetic body makes and uses insulin. Suppose that Alice, a non-diabetic, arises in the morning and has a mixed breakfast, that is, one that contains both carbohydrate and protein. On the carbohydrate side, she has toast with jelly and a glass of orange juice. On the protein side, she has a boiled egg. Her basal, that is, before meals, insulin secretion has kept her blood sugar steady during the night, inhibiting gluconeogenesis. Shortly after the sugar in the juice or jelly hits her mouth, or the starchy carbohydrates in the toast reach certain enzymes in her saliva and intestines, glucose begins to enter her bloodstream. The mere presence of food in her gut as well as the rise in her blood sugar signal her pancreas to release the granules of insulin it has stored in order to offset a jump in blood sugar, see Figure 1-2. This rapid release of stored insulin is called phase 1 insulin response. First phase insulin secretion begins within 2 minutes of nutrient ingestion and continues for 10 to 15 minutes. It quickly corrects the initial blood sugar increase and can prevent further increase from the ingested carbohydrate. As the pancreas runs out of stored insulin, it manufactures more, but it has to do so from scratch. The insulin released now is known as the phase 2 insulin response, and it's secreted much more slowly. The second phase of prandial insulin secretion follows, and is sustained until normal glycemia is restored. As she eats her boiled egg, the small amount of insulin of phase 2 can cover the glucose that, over a period of hours, is slowly produced from the protein of the egg. Insulin acts in the non-diabetic as the means to admit glucoseophilia into the cells. It does this by activating the movement of glucose transporters within the cells. These specialized protein molecules protrude from the cytoplasm of the cells and their outer surfaces to grab glucose from the blood and bring it to the interiors of the cells. Once inside the cells, glucose can be utilized to power energy-requiring functions. Without insulin, the cells can absorb only a very small amount of glucose, not enough to sustain the body. As glucose continues to enter Alice's blood, and the beta cells in her pancreas continue to release insulin, some of her blood sugar is transformed to glycogen, a starchy substance stored in the muscles and liver. Once glycogen storage sites in the muscles and liver are filled, excess glucose remaining in the bloodstream is converted to and stored as saturated fat. Later, as lunchtime nears but before Alice eats, if her blood sugar drops slightly low, the alpha cells of her pancreas will release another pancreatic hormone, glucagon, which will instruct her liver and muscles to begin converting glycogen to glucose, to raise blood sugar. When she eats again, her store of glycogen will be replenished. This pattern of basal, phase 1, then phase 2 insulin secretion is perfect for keeping Alice's blood glucose levels in a safe range. Her body is nourished, and things work according to design. Her mixed meal is handled beautifully. This is not, however, how things work for either the type 1 or type 2 diabetic. Page 62.